Thank you, and good afternoon, everybody. Thank you for inviting me to contribute to this webinar series. I'm delighted to be joining you today to speak about the EARL mapping exercise that we've done as part of PREPARE. And EARL stands for the Ethical, Administrative, Regulatory and Logistical Barriers and Solutions, and I'll be using that acronym a fair amount through my talk. So just a brief overview of the areas that I'm going to be covering. I'll start off with an overview of PREPARE, just to set a context for the work. And then I'll speak about our mapping exercise and give you some quite clear examples of the work that we've been doing. And finally, I'll touch on some future directions, both within and beyond PREPARE. So PREPARE is the platform for European preparedness against re-emerging infections. We're funded by the European Commission to provide really a research infrastructure across Europe with capability to respond to new and re-emerging infectious diseases with pandemic potential. And the primary aim of PREPARE activities is really to rapidly inform clinical management of new outbreaks in Europe. So our work is delivered across 5 platforms. There's a platform for pathogenesis studies. There's a platform for diagnostics, and both of those feed into that central practice platform, which is where our clinical studies are housed. And then there are 2 cross-cutting platforms, one focused on data sharing and data management, and another on training. So this slide gives you an overview of our clinical studies. We have observational studies in community and hospital settings. One is focused on acute respiratory infections in adults. Then we have pediatric studies focused on sepsis-like syndrome in infants and acute respiratory infections in children. And then there's an arbovirus study as well that's running in Southeast Europe. So that forms the MERMAIDS group of studies. We have adaptive platform trial in primary care, in community care, looking at clinical and cost effectiveness of antiviral medication for the treatment of influenza-like illness. And we have an adaptive platform trial in the intensive care unit, aimed at evaluating treatment options in adult patients with community-acquired pneumonia. Now, these studies are designed to produce valuable insights in their own right, of course, but they also have the capability to pivot to an outbreak response mode if required. And this research infrastructure is also available to deliver new study protocols if required. So this practice platform really was the base upon which we built our mapping exercise. Our work package is aimed at identifying and implementing solutions to key EARL bottlenecks to rapid implementation of large multi-site clinical studies in Europe. And we've developed a program of work working alongside the clinical studies, thinking about how they operate in interpandemic periods, looking for ways to optimize their delivery, but also in casting an eye forward to think about how these studies might operate in outbreak response mode. And we prepare annual reports of our work, and those are available on the PREPARE website. And it's really findings from these different strands of work that have informed our mapping exercise. And we've been thinking about mapping these barriers and solutions in 2 ways. The first is to consider the fairly logical process of delivering research, from study setup through delivery to dissemination of findings that can impact clinical management. And we looked to identify along this process where delays arise and to see what solutions there might be to speed up these delays or to work around them. Of course, without compromising the scientific and ethical integrity of the work that's being done. And that really is the challenge, as well as we see it, the opportunity for innovation. And of course, there's another way of thinking about these barriers and solutions, and this would be to map them across multiple levels. And we've borrowed this thinking from the socio-ecological model. And so you might imagine, for example, barriers and solutions arising at an individual level, things like patients or health providers, attitudes, beliefs, experiences of research and medicines, and so on. Interpersonal barriers or solutions, you can imagine this conversation, the research enrollment conversation, happening with greater or less effectiveness and efficiency. At an institutional level, we think about organizational systems or policies that influence the research. And in PREPARE, our intensive care unit adaptive platform trial is using an embedded design to provide a seamless front end for clinicians involved in the trial. The idea being that that is more efficient and interferes less with clinical responsibilities and duties. So that's a solution that's been identified at a more clinical systems level. And then, of course, there are other barriers and solutions that arise at a higher level, at regional, national, European, or international level. And here, an example might be the legislative frameworks. For us in Europe, an example is the law that governs how clinical studies of medicines are regulated across Europe. This is currently in the form of a directive, which is not legally binding across EU member states. And so what we found is that some EU member states transposed that legislation into national law and others didn't, meaning that there was considerable variability in legal requirements for setting up pan-European studies. The directive has now been replaced by a regulation, which is coming into effect in October next year, and that is legally binding across all EU member states, which hopefully will promote harmonization. So we've used these two frameworks to really integrate the various strands of our work and to give us a high-level overview in trying to map the complexity of these barriers and solutions. There are obviously interconnections across these levels, and it's equally important to be working from the top down as it is to be working from the bottom up. But let me give you some concrete examples of the work that's informed the mapping exercise. The first relates to the approvals required for research governance, so the ethical, medicines, and other local approvals, as well as contracting, which it was actually the contracting that we heard from PREPARE clinical studies that was the major bottleneck in setting up studies in a timely way. And what we did is we developed data tracking tools for observing the experience of the PREPARE studies, and these tools were developed and refined in an iterative process that included interviewing research staff to better understand where things had gone well and where there'd been substantive delays. And we've now taken that qualitative data to refine the tools further and to have a more efficient way of capturing those data going forward, but also to have a tracking tool that not just captures the time frames, but also can allow us to identify some of the common reasons for the delays, as well as some of the common reasons for the efficiencies where things have gone well. And this slide gives you some idea about how we can use these data. It's a simplified snapshot of the ethics review process for some sites, and you can clearly see there the length of time required to get ethical approvals, where the delay arose, whether it was from the ethics committees or whether it was from the researchers. And of course, we can go to our qualitative data to better understand some of this variability. And the data that we've collected thus far can also help us to identify where there's a favorable environment for rapid setup of studies, which of course can be used to inform rapid site selection in the event of an outbreak. But we've also been thinking more broadly to identify variations across countries. So, for example, identifying where fast-track approvals processes are available or provision for pre-approved protocols. And you can see these are very mixed pictures. There's definitely not uniformity across EU member states and associated countries. And the clinical trials regulation doesn't mandate countries to have a fast-track mechanism for review. We think that's going to be a major barrier to rapidly setting up cross-European studies. But having this overview, again, will allow us to identify where there's a favorable regulatory environment to rapidly setting up studies in the event of an outbreak. The second example that I wanted to raise today has to do with patient recruitment or enrollment to clinical studies in outbreak mode. So we wanted to understand stakeholder views, in particular, the views of potential participants, members of the public. What do they think about taking part in outbreak-related research? How should we invite them to do so? And how might we communicate with them about research and about research participation? We know that decision-making is not always rational, and yet we assume in the informed consent process, for example, that if we just give patients enough information, they will make an informed choice. In reality, decisions are often based on emotions, mental shortcuts, and perceptions of risk and trust. And so we feel there's work to be done in examining that enrollment process for different kinds of research to ensure that it's fit for purpose in an outbreak scenario. And by that, I mean that it is lean, efficient, and ethically robust. So we reviewed consent models that have been used in intensive care settings, and there's been innovation in this area. So critically ill patients typically have impaired capacity to make decisions, and there's a short time window within which to give trial interventions. And consent here can be given by a third party, or patients can be signed up immediately and consent taken later, either from a patient or relative. And of course, in some instances, consent can be waived altogether. And there is a legal framework for this now. These models have been written into an article of the Clinical Trials Regulation, but legally, these models can't be used where patients have decision-making capacity, and so they wouldn't apply to all kinds of pandemic clinical research. For example, research that's conducted in primary care or community care settings. So they're high-level guidance documents that address some of these issues and that highlight the importance of patient and community engagement as an ethical imperative to designing and conducting research. And we've done some initial public consultation work, particularly looking at these issues related to research enrollment. We also run process evaluations with patients who've been through prepared studies, and we're currently setting up a patient panel that can be rapidly convened to advise us on study-related issues if PREPARE were to move into outbreak response mode. I'll touch briefly on our public consultation work. We did this work across 4 European countries, in the UK, in Spain, Poland, and Belgium. And in doing this qualitative work, we used scenarios related to a pandemic flu outbreak. And the research focus was about evaluating novel diagnostics and evaluating the comparative effectiveness of routinely used medicines in community and hospital settings. So reasonably low risk research scenarios. And we selected these because they were similar to the PREPARE clinical trials. Now, we've presented this work at the Lancet Public Health Conference. We have a full paper under review, but we also developed this public-facing report of our findings. And the reason we did this was firstly to feed back to our study participants, but also to expand the discussion of these findings to a wider audience beyond academia in order to reach patient groups and in order to extend this into policy circles. So what did we learn from this exercise? Well, one of our key findings is summarized in this slide, and this captures the arguments put forward both for and against changes the research enrollment process for lower risk outbreak related research. Of course, with qualitative work, we're looking to set out the arguments rather than to see how many people agreed with this or not. And these were the arguments that were presented to us. On the one hand, patients are saying, look, the enrollment process puts me off. If I'm feeling ill, I'm not sure that I'm even going to make a sensible decision. Secondly, they're saying there's tremendous social value to this. They were saying signing informed consent, well, that's a little bit like signing terms and conditions. There's so much information to read. I'm really going to skim through it and then make a decision, yes or no. There's all this documentation. Who's really being protected? And finally, quite specific to this context was, what's the difference between being involved in research if the treatments I'm being exposed to are the same that my clinician would prescribe anyway? But of course, on the other side, there are very strong arguments about wanting processes, wanting regulatory oversight, wanting to be sure that the processes do protect them. But I think the take-home message from this is to be thinking about proportionality. So if we were to change our processes, in what way could we do it? Well, patients are saying to us they want simpler processes, they want simpler information, they wanted information to be given at different time points and in different ways, using images, for example. And they also suggested the use of opt-in or opt-out consent models for different kinds of research. And they drew parallels with this opt-in and opt-out consent models that are used for organ donation and the wider public discourse that's been stimulated by legislative change in that area. And that may be quite specific to the people we spoke to, because we did this work in Wales and in Belgium and in Spain, where, of course, they have an opt-out system for organ donation. We're interested in the generalizability of these findings. We've used these data to develop a public survey. We've completed data collection now from a nationally representative sample of 850 respondents in each of 5 European countries, as well as Canada, and we'll data collect in Australia and New Zealand in July to see how widespread some of these views are. So what have we learned, and what new directions is this work moving towards? Well, I'll set out 4 broad areas. The first is clearly to continue with our mapping work. So this is an ongoing and iterative process, but this is less about coming up with a definitive or exhaustive list of barriers and solutions. Rather, the aim is to stimulate a way of thinking about the research process, to embed reflexivity in the work that we already do, and to clarify a methodology for identifying barriers and solutions in order to prioritize the areas for change. There's a need to further develop this methodology and to develop tools for the mapping process to continue, not just in Europe, but also in other parts of the world. Secondly, we'll continue to develop solutions together with stakeholders, including the public. And we also need to be testing these solutions during interpandemic periods so that they're fit for purpose and ready to be evaluated in the event of an outbreak. There's no doubt that innovation is required, but innovation without evaluation would be reckless. We need to build capability and capacity for process evaluation of research as well within our workforce. Thirdly, in Prepare, we're particularly interested in influencing the regulatory environment in Europe. That's really a major barrier to the rapid setup of clinical studies. We need to be sure, for example, that fast-track mechanisms for protocol reviews are available across Europe, not just in select member states. That really is a priority. And the fourth area that needs development is communicating with the public, particularly related to research in an outbreak. We need to understand what these messages are, how they can best be framed and tailored to different audiences. And I'd just like to conclude by acknowledging my team. We're led by Alistair Nicholl at University College Dublin, thanks to our Prepare partners, our funders, the European Commission, and to our coordinator, Herman Goossens from Antwerp University. Thanks.